Now, beyond the insulin resistance syndrome, insulin resistance has a hand in many diseases, including these big three: diabetes, heart disease, and cancer, but also several others that you might not expect. I've already touched on body fat, but Alzheimer's disease, the most common form of dementia, stroke, arthritis, migraines, infertility in men and women, and fatty liver disease. Each of these diseases is either caused by or exacerbated by insulin resistance. So insulin resistance is extraordinarily relevant in these non-infectious chronic diseases that we're all worried about. Now, with regards to diabetes, and one of the central tenets of this talk, I think that if we appreciate the role of insulin resistance in type 2 diabetes, we look at type 2 diabetes with a far greater degree of accuracy. So in looking at insulin resistance, commonly the typical marker that we're searching for is looking at glucose. That's what we want to look at, and that's what we want to track. And over the life of a person progressing towards type 2 diabetes, the glucose levels are going to look something like this, starting normal and then becoming progressively elevated. Now, this is excusable, despite me disagreeing with it, and I will make the case that it is wrong. I think we can nevertheless be sympathetic to that perspective, and certainly sympathetic to people who hold it despite the evidence. Now, the evidence in favor of it is historic and scientific. Very briefly, because I'm not a history professor, the historic reason is excusable, partly because the most common manifestation of someone with diabetes, most specifically type 1, but even type 2, would be that they would be urinating a lot, the polyuria. Due to the high levels of glucose, the kidneys can't resorb that glucose, and so the glucose will stay in the urine within the kidneys, and that will pull water with it. So the person's producing a high volume of urine, and it will be enriched with glucose. Now, second and more modern, it would be the scientific justification, and that is simply that it is easy to measure glucose. When you can oxidize the nutrient on a teeny little strip that has enzymes on it, it gives you a lot to play with. Much easier to measure, I should say, to be clearer, as opposed to trying to measure hormones on something like this. So measuring glucose is easy to do, and thus it became relevant because people could track it. We can all measure that on our own at home, let alone in a doctor's office. Now, with that sympathetic perspective in mind, let's transition to making the case that it's not excusable and nowadays, and that insulin ought to be the metric that we're scrutinizing when we want to understand type 2 diabetes. And if we superimpose insulin over the lifetime of someone progressing towards type 2 diabetes, it would look something like this. It starts low, it elevates significantly, and then it starts to come down, but it is nevertheless higher than it was before. That is so important because so commonly this part here, where insulin starts to drop and then glucose starts to climb, commonly in the literature we will say insulin is insufficient to keep glucose in control. And that leads some to erroneously conclude that insulin is essentially zero, and we use that as justification for insulin therapy, but it is not. While that is technically accurate language, it is misleading to say that insulin is insufficient. We should be clear that it's insufficient to keep glucose in check, but it is still elevated. Anyway, insulin has that progression. I want to note two specific timelines as if we were moving along that x-axis through time, through the life of the person. This first stage is the insulin resistance stage, and you'll note that it is defined by elevated insulin but normal glucose. This is where most people fall nowadays, unfortunately, certainly in the US and other countries. And then as this progresses, in not everyone, but many of these people with with insulin resistance will progress towards type 2 diabetes, but not all of them. But this is now where insulin is still higher than normal, but it may start to drop, and now glucose levels will start to accelerate and climb. So insulin is elevated and glucose is elevated. But insulin is the key variable here. You can see how it starts to climb so much earlier than glucose does. And this is played out in the literature, this interesting report finding that in people with type 2 diabetes, if you're looking at insulin and not glucose, we can detect changes a decade, and I would submit more than 1 decade earlier than the glucose changes. And if we're looking at insulin resistance, then this study is making the case that it's insulin, not glucose, that should be used as the marker of the disease. Now, unfortunately, and I alluded to this a moment ago, when we focus on glucose, we do whatever we can to push the glucose down, including bringing insulin back up to where it might have been and even beyond, so to super physiological levels of insulin. So we begin treating the patient with insulin therapy, and then that will most certainly push up the insulin, but conventional medicine would say, who cares? We don't care about the insulin, we care about the glucose, and because the glucose is going down, well, then we're doing what we want. The tragedy in this paradigm, and I won't take the time to show you the data, but one, we not only have a significant increase in body fat, the diabetic who begins insulin therapy can expect to gain up to 10 plus kilos easily of fat. The risk of heart disease will climb by multiples. The risk of cancer, mortality, actually dying from cancer will go up, one particular study, by about 90% with insulin therapy. So this has meaningful consequences. And while the one consequence might be a benefit, namely lowering glucose, it comes at a heavy price, where the diabetic can most certainly expect to gain weight and die sooner. And that should be the outcome that matters. So what is a takeaway then, as I'm wrapping this up? If we look at insulin levels, I make the cutoff of around 6 microunits per mil. This is based on evidence, and I have some studies linked here, where healthy people, based on people not adhering to a Western diet or a processed foods diet, I shouldn't call it Western, it is global, but a diet that is based on processed foods, they're going to have insulin levels around 4 microunits per mil. And these are people who have extremely low levels, if any, diabetes at all. Importantly, the average American has insulin levels of around 9 microunits per mil. And oddly, that fits within the healthy range of most clinical cutoffs for insulin. Unfortunately, there's no consensus on these numbers, but that would fall within a healthy range on most blood tests. And I think that is misleading, because the average American, of course, based on that study published last year, is metabolically unfit. Remember, 88% of these people with an average insulin of 9 microunits have aspects of the metabolic syndrome. So 6 microunits range that's in the middle of these two cutoffs is going to be one that people should shoot for, and thank heavens they can, based on dietary changes that I won't take the time to describe now, but most certainly other people will in this meeting. And indeed, the dietary strategy that I believe is best is encompassed in the very name of this low-carb Sydney meeting. Now, so in conclusion, these are the aspects of the insulin resistance syndrome, nowadays referred to as the metabolic syndrome. And guys, thank you for listening. I hope this has been instructive. Again, my main hope is that we can appreciate the role of insulin and insulin resistance, not only in diabetes, but also in virtually any disease related to cardiometabolic disorders. These are the labs at BYU that I'm associated with, and there are my social media handles. Thank you for listening again, and I hope you found it instructive.